All right, welcome back everyone. So here we're going to pick up and we're going to begin talking about the thyroid gland as our next endocrine gland. So the thyroid, first off, just consider where the thyroid sits, right? So the thyroid sits just below what we typically refer to as your Adam's apple, right? So if you feel in your neck your Adam's apple, that little divot right in the middle, that's called your laryngeal prominence. And if you go maybe like 2 finger widths down, that's the approximate location of your thyroid, right? The thyroid has a left and a right lobe connected by something called an isthmus. It's extremely vascular, right? So there are thyroid arteries that supply the thyroid. There's also thyroid veins, as we'll see in a moment. And this is helping to, again, supply the thyroid with the blood supply. But think about the role of the endocrine system. As we said, you have to have a blood supply to transport hormones, right? And then we'll look at these various microscopic features of the something called thyroid follicles. We'll look at these microscopic structures here in just a moment, but they're composed of various types of cells that produce a couple of different types of hormones, one being the thyroid hormone we already mentioned, and then one being a different hormone called calcitonin that's involved in calcium regulation. So here's the anatomy of our thyroid, right? So we can see our thyroid here right in the middle, right? So here's your hyoid bone. Here is your laryngeal prominence, right? This is called your thyrohyoid membrane. Here's your the laryngeal prominence here. And then here you can see your thyroid just below, right? And this is our trachea, of course, right? So you see the same thing over here, just you see it labeled a little bit more. So here we can see our larynx with our thyroid, or our laryngeal prominence, right? We see our thyroid below. We see the isthmus along with the left and right lobes of the thyroid, and then we see our trachea down below, right? So if you zoom in and we look at a microscopic image of the thyroid, we see these things called thyroid follicles, right? Thyroid follicles. So each one of these circular clusters, right? So you see one here, this large one, you see one here, you see a small one here, you can see the same thing over on this side, right? Each one of those is a thyroid follicle lined by what are called follicular cells, right? So all of these kind of cuboidal cells, right? So this epithelium is a simple cuboidal epithelium that lines this region here. These are follicular cells that produce thyroid hormone, ultimately, that will release it. And then there are other smaller cells that are called parafollicular cells, right? And they're a little bit larger. But these are the ones that are producing something called calcitonin, right? So you may also see these called C cells, right? C cells are parafollicular cells. These are producing calcitonin, right? Now, if you look on the inside of the follicle, you'll see this kind of pinkish substance, right? All of this substance that you see here, on this side, it looks a little more orange. This is something called colloid, right? Colloid. And colloid is this kind of protein-rich, kind of gelatinous-like substance that is essentially where we're going to produce our thyroid hormone, right? And so we'll look at the steps of that process here in just a moment. But it's mostly occurring here within the colloid of the follicular of the thyroid follicle itself, right? So here, this is a basic overview of how we make thyroid hormone. So there are a few things that I want to point out, right? First off, thyroid hormone synthesis requires iodide, right? So iodide ions, right? And so we get pretty much all of the iodide we need through our diet, right? So next time you go to the grocery store and you get a little container of Morton salt or something, look at it and it'll say iodized salt, right? So it is sodium chloride that has been enriched or has had iodide ions added to it, right? So we have to take up iodide, okay, from the blood, okay, into those follicular cells, right? So into those follicular cells here that are lining our follicles, okay? And then two of those ions combine to form iodine, okay, molecular iodine, right? That iodine is then transported across the follicular cell lumen and into the lumen of the follicle itself, right? So this is where you would have your colloid all in this space here, right? While that's happening, you're also producing, inside the follicular cell, you're producing something called thyroglobulin, right? And thyroglobulin is just a protein, right? So it's a string of amino acids, right? That's all it is. It's just a protein. That thyroglobulin, it's made via protein synthesis, right? So ribosomes, transcription, translation. It's packaged into a vesicle in the Golgi apparatus, and it's then exocytosed into the follicular lumen, right? Again, where we have this colloid, right? So the colloid is this iodine and all of this thyroglobulin kind of all together. What happens in the colloid is summarized with this graphic right down here, and I'm actually going to skip to the next slide because it has a zoomed in image of it, right? So what we see is this long thyroglobulin protein strand, right, this red strand, and then attached to it we have tyrosine molecules, right? Tyrosine amino acids is what they are. Attached to these tyrosine amino acids, you will have either one or two iodine molecules, right? And these are attached via an enzyme called thyroid peroxidase, right? You know it's an enzyme because it ends in ACE, right? So for one tyrosine, it can either receive two iodine molecules, or it can receive just one. Okay, it can receive just one. So what you end up with is you can end up with either two what are called diiodotyrosine. You can have one and then another form together. They bind together, and that forms something called pre-T4. Okay, so T4, the 4 comes from 1, 2, 3, 4 iodine molecules. Or you could have one that only has one and another one that has two, and those join, and it forms something called pre-T3, right? Pre-T3. So you can get pre-T4 or pre-T3. Okay. And so in this case here, what it's formed is you have one tyrosine here that's had two iodine molecules added. You have another tyrosine here, which has had two iodine molecules added, and both of those together bond and they form pre-T4. And you can just count the iodine: 1, 2, 3, 4, and you call this thyroxine. So this is this is the thyroid hormone, essentially. This is what will be the thyroid hormone. Okay. So if I go back, after you have produced that pre-T4, right, it is going to be cleaved off of the thyroglobulin, right? So it's going to be detached. It's going to be brought in. It's going to be endocytosed into a vesicle. It's going to the thyroglobulin is going to be cleaved off by the lysosome, and then the pre-T4 is going to diffuse back into the blood, and then from the blood it's going to circulate out into the body and bring about its effects somewhere, right? Somewhere in the body, right? And again, a lot of tissues have thyroid hormone receptors, right? Just like many of them had growth hormone receptors, right? So if I go back another slide, you can see the vascularity, right? So here's a bunch of blood vessels, right, in this thyroid tissue. And again, that's where you're secreting this thyroid hormone, right? You're secreting it back into the blood supply, because we've said several times that endocrine organs are extremely vascular, right? And so this is kind of the pathway here for promoting the production and release of thyroid hormone, right? So first off, you start off in the hypothalamus, right? You have TRH, right? Remember TRH from the hypothalamus, that stands for thyrotropin releasing hormone, right? TRH, thyrotropin releasing hormone. TRH causes the anterior pituitary to release TSH. Remember, TSH is thyroid stimulating hormone, right? Thyroid stimulating hormone triggers those follicular cells that we just mentioned, right? Those follicular cells here to begin this process of producing thyroid hormone, right? And it's either going to be in the T3 form or in the T4 form. Okay, so you can call it triiodothyronine or tetraiodothyronine. So tetra meaning 4 and tri meaning 3, right? And they're going to move out into the periphery via the bloodstream and bring about their effects somewhere else, right? So this basic axis here, hypothalamic pituitary thyroid axis, TRH from the hypothalamus stimulates TSH from the pituitary, anterior pituitary, which stimulates TH or thyroid hormone from the thyroid, right? So TRH, TSH, TH, thyroid hormone, right? So here is that pathway in a pictorial form, right? So you have TRH from the hypothalamus stimulates TSH from the pituitary, which stimulates thyroid hormone release from the thyroid gland, enters into the bloodstream, and then again, it's acting on a myriad of different structures, right? So neurons, liver, connective tissue, adipose tissue, lungs, heart rate, right? All in an effort to promote or increase metabolic rate, right? So you can look at all of these effects, and all of them you would expect to have in a increased metabolic state, right? So increase heart rate, increase breathing, increase fat breakdown, increase breakdown of glycogen into free glucose, right? Increase the glucose uptake into the cells for maybe protein synthesis, for ATP production, something like that, right? So the big thing here is we are promoting increase in metabolic rate, right? Now you can have issues with thyroid secretion, thyroid hormone secretion, in what are called primary and secondary pathologies, right? And essentially the difference in this is in a primary pathology, it's going to involve the hormone, it's going to involve whatever the organ is that actually produces the hormone, right? So in other words, for a thyroid issue, right, a primary thyroid pathology, it's going to affect the thyroid itself, right? In a secondary pathology, it's going to affect some other organ that then affects the thyroid, right? So it may be an issue with the hypothalamus, or it may be an issue with the anterior pituitary, right? So there are different ways in which you can have alterations in the normal function of this pathway, right? So here are again major effects of thyroid hormone. So we already said, big thing is affecting cellular activity, so increasing metabolic rate, increasing protein synthesis, as we said. We alluded to earlier that depending on whether you have 3 iodine molecules or 4, you get T3 or T4. Thyroid gland produces more T4, but you typically use T3. So the T4 is able to be converted into T3, which is more readily available and more readily useful in our body for our various metabolic processes, right? So we already said, again, increasing metabolic rate, increasing protein synthesis, amino acid, glucose uptake, again, using these for the production of ATP for cellular respiration, right? So for making energy. ATP production, again, so increase glycogenolysis. So this is breaking down glycogen, making new glucose, decrease glycogenesis, right? Remember that is making glycogen, right? So many of these effects, they're the same effects we saw when we did growth hormone, right? Whenever we did growth hormone, right? In adipose tissue, increasing lipolysis. This also is saving glucose for the brain, and this is something called the glucose sparing effect, right? So our brain you can think of as kind of a glucose specialist. It really only uses glucose. So the glucose is going to be spared for use in the brain, and then other tissues, and other tissues can use glucose as well, but then other tissues will also be able to use fats from lipolysis as well, right? Increasing respiratory rate, as we saw, so supplying the additional oxygen that we need for ATP production, and then of course increasing heart rate and force of contraction to then circulate that blood to pick up the oxygen to then send it out to the tissues, right? So we can also have heart effect with epinephrine, norepinephrine. So this can cause the heart to increase receptors for epinephrine, norepinephrine. Thyroid hormone can. So if you think back to AMP1, right, when we did autonomic nervous system, if you increase the number of receptors for epinephrine, norepinephrine, right? What are the effects of that going to be, right? What does epinephrine, norepinephrine do on the heart? What increases the rate and force of contraction, right? Whenever it binds to the heart, right? So there are a number of different thyroid disorders, just like there are lots of other disorders as well for other endocrine organs. A few different main ones are hyper and hypothyroidism, so simply meaning excess production or insufficient production, right? So hyperthyroidism and hypothyroidism, right? So essentially, an easy way to think about this is to think about what thyroid hormone normally does, right? Well, we just went through it. We said that it increases heart rate, increases respiratory rate, increases metabolic metabolic rate, so the uptake of glucose, right? All of these different effects that we were looking at here, increased protein synthesis, metabolic rate, respiratory rate, all those things. So if you have hyper or hypothyroidism, what you can essentially do is take those normal effects and either turn them up if it's hyperthyroidism or turn them down if it's hypothyroidism, right? That's kind of an easier way to think about these things, right? So if you turn it up, you have an increased metabolic rate. Because you're constantly using energy because of this increased metabolic rate and you're using your different nutrient sources, you may have weight loss. You typically have hyperactivity. Patients may be kind of jittery, kind of shaky. They may have a tremor, and they may also be intolerant to heat. So they become hot very easy. They're maybe sweating, right? And so this could be caused by you take too much thyroid hormone. Maybe you have hypothyroidism and you're taking T4, but you take too much, right? Something like that. You have damage to the pituitary gland, something like that, right? So a common condition that causes hyperthyroidism is called Graves' disease, right? And this is typically treated by essentially destroying the thyroid with radioactive iodine, and then you take T4 medication, right? You take the hormone. Hypothyroidism is essentially the exact opposite. So low metabolic rate, lethargy, cold intolerance, weight gain, sluggish, lack of energy, things like that. So this could be caused by poor iodine intake, right? Again, for us in the United States, it's not a huge issue because we get most of our iodine, pretty much all of it, in our diet. Maybe some type of post-surgical trauma to the thyroid gland. Maybe there was a surgery in the neck and it damaged it. So a condition is called Hashimoto's thyroiditis. And the big thing here is you take thyroid hormone, right? You take it as a supplement to replace it, right? And then another condition, you can have a goiter. So a goiter is this large increase in the neck in terms of the size of the thyroid gland, typically due to insufficient dietary iodine. But again, in developed countries, it is typically not a major concern, right? And then the other hormone that we mentioned with relation to the with regards to the thyroid is calcitonin, right? And so this doesn't have really as much to do with the metabolic activity regulation that we talked about with thyroid hormone, but more so with involving calcium, right? So calcitonin is produced from those parafollicular cells, also called C cells, and it's acting to inhibit osteoclast activity, right? And so all this is going to do is it's going to help to lower our blood calcium, right? So the stimulus is a high blood calcium, and it's going to act to decrease blood calcium, right? And so here's a good kind of feedback loop, if you will, for calcium regulation with calcitonin. And then we also have a similar kind of antagonistic hormone that does the exact opposite, called PTH, or parathyroid hormone, that we'll talk about whenever we do our parathyroid gland, right? So we will stop there and we will pick up on our next part looking at the adrenal glands.